All right, everyone. It's about 9:02. Welcome to our Saturday morning brunch series. We are so excited to see so many of you here. This is hosted by the VCU Huntington's Disease Center of Excellence, but we did invite people from all of the Parkinson's Disease and Movement Disorder Center because we felt that this topic really broadly applies to all care partners who are navigating intimacy in the face of chronic disease. So welcome. We are really excited about this topic today. Before we begin, I just want to do a little bit of housekeeping. You will see that there is a Q&A button at the bottom of your screen. If you have any questions during the talk or after, please feel free to type it in there. There is a little button where you can make it anonymous. If you raise your hand, we may reach out to you either by chat or encourage you to put something in the Q&A. This is also being recorded, so you can come back to it and watch it later. It will be posted on our VCU website. Um, I'm Dr. Stephanie Bissonette. I am the co-director of the Huntington's Disease Center of Excellence here at VCU, along with Ginger Norris, who's also with us today, who is also a genetic counselor. And we are very excited to introduce Amber McCarthy to you. Amber is a licensed social worker at the University of Texas Health Sciences Center at Houston. So thank you for getting up so early and joining us from the Central Time Zone. And Amber is the social worker in their Huntington's Disease Center of Excellence, as well as a youth social worker and support group facilitator for the HDSA since 2021. I have seen her give this talk at the HDSA National Convention, where she has done this multiple years in a row. And there is a lot of really great information in here that I know you're all going to find very helpful. So without further ado, thank you, Amber.
Thank you so much, Dr. Bissonette. Let's see if I can take over the sharing. Okay, can you all see that? Wonderful. Okay, so I'm really honored to be with you all this morning. I'm really excited to talk about this. I think it's super important. Intimacy, as you know, is, it's about relationships, usually really close relationships. Sometimes that can change over time for all of us. Um, and there are different types of intimacy, as you know. There's emotional intimacy, psychological, which is that closeness, where you're sharing, everything about yourself and what you hope is going to happen. Physical, which I think sometimes when we think about intimacy, we're just thinking about sexual, but there's also so much that's important about closeness of, hugging and small touches on the shoulder as you walk by, and just really small ways to create connection that sometimes we have to be more intentional about. And I really want you to consider that. And then, of course, there's sexual intimacy, and that's a really important part of humanity as well. And I do want to say, please put things in the Q&A. I usually do this in a very interactive way, so it's a little weird to be speaking into the void. So please, as we go, feel free. I encourage you to put your questions, put your comments. Okay, so I want you to think about your relationship. And this is sort of we're thinking about this as like your care partner in a, romantic relationship with, your care partner, you're someone who has an illness. Think about your relationship. How did you meet? What attracted you to one another? What have you appreciated about one another then and over time? What are some of your best memories? How did you, show your love? Think about the timeline of your relationship, which if you're dealing with a neurodegenerative disorder, I think that probably has a big moment in it. But what happened before that? What happened with your relationship when you were diagnosed or when either of you started to see symptoms? How did that change? Where are you at in relationship to that diagnosis to now? And also, what we think of as like the well partner also has their own health, or is that person dealing with health concerns? Have there been any really bright moments in your relationship, in your lives? Have there been struggles outside of illness? What are some of the strengths? What are some of the challenges? Does anyone want to share in the Q&A? And I can share something about what you think about when you think about your relationship. Did you like someone's laugh or do you love how they were super kind? or it's too early in the morning and I'll move on. Okay. But just important as you're thinking about intimacy that you think about the story, the narrative of your experience together. Oh, okay. So here is one theory. This is a very old theory of how relationships come together and fall apart, but it's one that, people continue to reference. And so there's this idea of like you're meeting, then you're kind of like getting to know each other with the experimentation, kind of feeling each other out. Then you're starting to spend a lot of time together. Maybe years ago, you would spend a long time on the phone. You would come together, and then integrating, meaning like you're really starting to integrate your lives. Spending a lot of time together, bonding. That's really, really, it's like, okay, we are official, and maybe that's, marriage or not, but you're a couple. And then as you come apart, there's differentiation, which is normal. That just means that you're becoming different than you were before. And how are you navigating that? And if you're not intentional about it, you can come apart, right? So then you're kind of circumscribing, meaning you're coming further apart. Things get kind of stale. And things can really then, fall apart where you're avoiding each other because it's awkward and the relationship ends. So the goal is to recognize that this is normal. And when you start to differentiate, when you start to kind of come apart, when you start to create a little more distance, that you recognize that. And it may be that that happened a long time ago, but that doesn't mean that you can't still come back together. So you can kind of start at the beginning again, if you will, although it's more complex. Okay, so relationships change. We as individuals change, and then our relationships change. And what that means is that it's normal for everyone, for all of our relationships. But then when we add illness, challenges, that makes it even more complex and difficult. So we have to put more effort into it. So, one thing that we can think about is adaptability. So, are you willing to be flexible as these changes happen? And so, Esther Perel, who's a couples therapist that got pretty famous, says that, adaptability in couples is responding to these changes that we know are going to happen. But if you do it with good communication and being flexible, you're going to have, a better time of it. So I love that she says, just like a big body stretch, pushing past our resistance. Because I think it's really easy when things change. Most people feel uncomfortable with change, especially if it's a negative change. I think that resistance is so easy to come up and it's so natural that we kind of sometimes don't even know that it's happening. So I think if you can consider that, try to recognize it in yourself, think about that visual of stretching through it, um, and recognize that you've made changes before. There have been changes, more changes are going to happen. How are you adapting? And that allows you to stay connected. Okay, so let's think about chronic illness and how that changes the relationship. So here's one study that looked at, how people were dealing, how dyads, how couples were dealing with this. So they were reporting that, they recognized some themes that the partnership kind of disappears behind the disease. The disease can kind of take over. It can take over for the individual, for their identity, can take over the dynamic in your relationship. Um, and how are you recognizing that that's happening or not? How are you, responding to that, adapting to that? We absolutely see that everyone struggles with the changing tasks and roles. So it may be that the person who now has this diagnosis used to do more housework, used to manage the children, used to manage the finances, used to, do certain things. Every relationship has a different division of labor, if you will. But that starts to change when someone isn't able to do the same things that they used to do. So sometimes that happens with a conversation and is done very intentionally. And other times it just sort of slides into, well, no one else is cleaning the bathroom. I guess I'll do it. And we know that that can cause resentment. So think about that. Think about, having an intentional conversation about those tasks and roles. Um, making a list of what are the things that have to get done What can I do? What can you do? What can we outsource? Which, sometimes when someone is sick and they have to stop working, you don't have the money to pay a cleaning person. But do you have friends that can support you? Can you ask your children to help or your parents or your siblings? And that can be really uncomfortable. But I think really spending some time considering tasks and roles. And then I didn't put this in there, but there's a book called Fair Play that really goes into this. And there's a book, they're little like playing cards, if you will, that prompt you to, identify each task, each household task, and divide that up intentionally. Not the best of times. It's not the most fun, but I think it makes life easier to, be really intentional about it. And then, of course, while we're here, everybody mourns the loss of intimacy. And that happens for a variety of reasons. And it's important to allow yourself to feel that sadness and then think about how to move forward from it, and how to strive to rebalance the relationship, which was what I was suggesting about the tasks and roles, but also about your, interpersonal, physical, sexual intimacy. Okay. I do work at a Huntington's Disease Center of Excellence. I'm going to talk about Huntington's a little bit. I've started to add some other movement disorders, and it just got to be too much. So we're just going to talk about HD, but know that a lot of this can be similar, in other diagnoses. And I want you to, whichever illness you're dealing with, I really want you to learn about it because when you learn, even though sometimes that feels scary, especially if you're the partner, that can inform your experience interacting with your loved one. So for Huntington's, motor symptoms are the physical symptoms, right? So chorea is the involuntary movements. Ocular motor problems, like vision and moving. There's some rigidity, spasticity, cognitive problems, right? So people's processing speed slows down. You might start to, notice that the person's repeating themselves, or you need to, as the care partner, repeat. Um, Psychiatric symptoms, depression, anxiety is the most common mental illness in the general population. Um, Irritability can be very difficult. It's hard to have a great relationship when the person's just super moody and grumpy, getting agitated. Psychosis is when someone's kind of not connected to reality. And obsessive compulsive behavior or something called perseveration, where people just kind of get stuck on an idea, that can be very difficult to deal with. The cognitive changes and the psychiatric changes often start to show up in subtle ways, or maybe not so subtle ways, before the physical symptoms. And that can really um, change a relationship before you even know that HD is part of what's happening. And so it can be very, very difficult. By the time someone gets a diagnosis, we have an explanation for their personality changes. There can be a lot of resentment. There can be a lot of, negative history that's happened. And so, can we help you recognize that and be intentional about overcoming it? Probably helpful with a professional to help you, move through that. But I think it's really important to, as again, you're thinking about that story of your relationship, consider what role has the actual illness played in the changes and in how things have developed. Sometimes we meet people and they've already been divorced because of this. I mean, it really can have dramatic impact. Okay, so again, a little bit about HD. I'll try to go through it a little quickly, but here's a paper that looks at here are all these symptoms and how is everyone perceiving it? How is the person living with HD seeing it? How is their partner or caregiver seeing it? So again, cognition, I just want to point out to you perseveration where you get stuck. The person living with HD was seeing 25% reporting it, but their partner was seeing it at 47%. However, the person living with HD was recognizing memory problems at 32%, and their partner was recognizing it at 11%. So I just want you to think about that difference, that disparity in how we're seeing symptoms and how understanding symptoms allows us to have an explanation and a framework to think about how the person is behaving and how then the person who is like the well partner can respond and and maintain good relations, maintain a positive experience for everyone. and that is challenging. So again, here's the emotional behavioral discontrol is what they wrote in the paper. And again, just take a look at the differences. Some of them are very similar. So aggression, everybody kind of saw it the same way. Depression, people saw the same way. But anxiety was a little bit underreported, if you will, by the partner compared to the person who was living with it. Motor, again, the physical experience. So just something for you to keep in the back of your mind. I have not looked to see if there's a similar study for other illnesses, but think about it as a concept at least. So here, this is getting a little bit old. This was from 2015, but there's a handbook of clinical neurology, and there's a whole chapter on relationships and sexuality. And they reference a study that I could not figure out how to access, and it's kind of old anyway, but I thought it was really important that they met with people who had done genetic testing like 3 years afterwards. And they said that, wow, the partners of the people who had tested gene positive had the same levels of distress as the people who are living with the disease themselves. So I think it's really important for, again, both partners to recognize that there's a person who's living with the illness, which of course is a very, challenging experience, but their partner is also really distressed for their person that they love, distressed for themselves and how they might be taking on more responsibility. Thinking about the future can be difficult. So how do we support you both in that? Okay, so sexual dysfunction in HD is really common. The prevalence is quite high. Again, this is kind of one study. There's some variability. Hyposexuality is a loss of libido, and hypersexuality is more than usual. Here are some ways that sexual dysfunction shows up in both women and men. So here's the hyposexuality, again, significantly higher, lower sexual drive, which, this is an important part, again, of our humanity, of your relationship. But if one partner is not interested, what does that do for the relationship? How does the person who's not interested feel about that? Do they feel guilty? Are we talking about it? We're probably not talking about it. People don't talk about it. How do we, start those conversations? And again, you can do it on your own. You can, talk with your physician. You can talk with your therapist. Talk about it at support groups. I'm a big fan of talking about it. If you can't talk. Okay, so how can we treat it? You can treat it with medication, with psychotherapy, sex therapy. It's really important that you learn about apathy. So apathy is just the meh, don't really care one way or the other, not super excited, not super upset, blah. And that sounds fairly benign until you start living with it. And so there has been some research that shows that even outside of sexuality, your, relationship, when the people around someone who has apathy encourages them and gets them like, hey, let's go to the dinner anyway. Let's try it anyway. Let's, let me hold your hand, start small. The person who's experiencing the apathy, when they start to engage after the fact, say, well, I didn't really feel like it, but I'm glad I did it now. So hindsight's 2020. So I think that's important if you're someone who's experiencing apathy to consider like, well, I might actually be glad that I do this. Again, you need to make your own decisions. We're not trying to, coerce anyone, but also just really, having that conversation of like, you might actually enjoy it, give it a try. It's tricky. I'm telling you to like walk this tightrope, both of you. And it's just really important to acknowledge that and to try. And that can be exhausting too. That's why you both need support. So hypersexuality is a lower prevalence, but it does exist. So that's just, increased libido. Paraphilia is where it's a little more dramatic sexual behavior, quite dramatic, as you can see. And, this is later in the disease, and it's a lot to deal with when it does happen. So just want to acknowledge that that is an issue and that it's one that you need to ask for help about. So treatment, definitely medication, maybe psychotherapy, maybe sex therapy. Kind of depends on where the person is in the disease, how effective that might be. But you have to think about safety. So if you're experiencing hypersexuality, if you're trying to take care of someone who's experiencing it, really need to work with your physician. Super excited that you're connected with this team. Please reach out. You can educate law enforcement because sometimes it does become a scenario where they need to get involved. Try to balance restricting what the person's doing while allowing them to, maintain their independence, set boundaries and maintain them. So sometimes you can imagine if someone is experiencing hypersexuality, they can be very forceful, they can be stuck on the idea. It can be very difficult for the other person. I'm sure it's difficult for the person who's experiencing it, but it can be difficult for the other person to figure out where to set that boundary. And that kind of depends on the relationship, history, the assumptions that you make about what your relationship entails. I think it's really important to get help and to know that you have a right to set boundaries. You don't have to, entertain the person's every request. And you can provide non-sexual connection. You can be strategic about avoiding triggers. Get support because it's just super tricky. Okay, we're going to shift over to ambiguous loss. So this is back again to, this affects everyone. Ambiguous loss is just a loss that's unclear without resolution or closure. So, we think about death and loss and grief around that, but ambiguous loss is when you're, experiencing changes, experiencing loss, but it's a little bit smushy. And with these neurodegenerative diseases, it happens over time that you're having loss after loss. So I like the idea of like the duality of gone but not gone. Um, and it's this, ambiguity where we, as most, people living in the United States, like certainty. Uncertainty is very uncomfortable. I really also like this quote of like, you have this huge loss, but there's no sympathy card. People don't recognize, the people in your life aren't necessarily going to recognize the grief that you might be experiencing. Um, and this really colors your interpersonal relationship because you might both be feeling sad um, about these changes, and you might not be talking about it. You could talk with one another, get support. But it's this mourning um, that you're experiencing. So there's this idea of prolonged grief, grieving the person who's still alive but different, and also for the person who's experiencing it. You still have your life, you're still trying to live a full life, and yet there are limitations. It's not looking the way that you had envisioned for yourself. So this idea of ambiguity, of things being fuzzy, can get in the way of acceptance. Um, and so just something to think about of like recognizing when there are losses, recognizing that it's something to be grieved, spending a little time on it. Because otherwise, as that next bullet point, you can feel helpless. Um, and we don't need to feel that way because that gets in the way of your quality of life and the relationships. So there are these different ideas of like uh, premature closure, meaning sort of writing someone off when they're still here, which is not great for anybody, or everything's fine. These two ends of the spectrum that really just aren't accurate to anybody's experience. So trying to increase your tolerance for the middle ground and the fact that it's gray, that you're living in the gray area, not that black and white. So can you hold two opposing ideas using both and thinking is this phrase that two contradictory ideas can be true. And then I really like this focus on the relationship more than what's normal. So there's sort of like, if we can get to accepting that this is what it is, how do we make the best of this? How do we create a relationship that is what we want it to be within the constraints that we have instead of what we had before or what we're envisioning for the immediate future? Um, and again, that sort of is, you have to do a little work around that of accepting that this is where we're at. And so how can you, think through what's important to you, what's important to the other person, what are y'all enjoying now, and really put some energy into that. Hope lies in your perception and ability to change. So again, that stretching through. I know it's a big bummer that you have to do the work. Okay. Then there's this idea of chosen family. So creating connection with other people for both of you. There's a lot of research right now about loneliness and how bad that is for us. Everyone, not just if you have an illness, not just if you have an illness in your family. Um, what are small ways that you can create connection? Are you leaving your house? Are you, walking your dog? Are you seeing your neighbors? Are you, going to your house of worship? We see there's, research that shows that people stop going to their place of worship because of lots of barriers. I was talking to someone the other day and I was like, well, the service is at 9 o'clock and we're not awake at 9 o'clock. Like, okay, well, is there something else that you go? Could you go to the meeting, in the middle of the week that's in the evening? But just really getting support from your community, from your family. And I like the idea of like, who's there for you? Who was in the past? Make a list. Make a list, maybe put it on your calendar of reaching out. Because when you are supported, it's easier for you to connect with one another because we're not supposed to be in isolation. Okay, so here are some other strategies. Thinking about uh, rituals and celebrations and how do you, again, work to be intentional about um, the things that you used to do and how they're different now. One thing that I think about is like with the holidays that just happened, people who are having cognitive changes can find it really overwhelming to meet with the whole family. There's a lot of people talking, there's a lot of things going on. And that's a loss too, of like, okay, well, it's not the same experience that it used to be. Do we want to not do it the same way that we used to? That's hard. We want all 20 people there, but maybe that's not going to make sense. So how can you shift it to make it work for you? Is that, you know, more smaller gatherings? Is that you go for a shorter period of time, take a break? But again, with a focus on continuing to be connected. Um, so, just some ideas. I like this idea of routine connection, of having it on your calendar. I really encourage people to talk to their friends and be like, hey, could we have lunch once a month? Could we have lunch twice a month? Um, could we go for a walk together? Could we go to the grocery store together? Wherever it is that makes sense in your life. But when all of these changes are happening, it's easy for those relationships to fade. And really don't want that for you. It takes more effort, but I think that most people find that it's worth it. Okay, so again, this is ideas for both of you, guidelines for the journey. And again, this is from this book called Loving Someone Who Has Dementia by Pauline Boss. And I think that her recommendations apply to both people. And dementia, cognitive changes with neurodegenerative diseases happen over time. So it's not like a light switch flips and the person is completely gone. And also, dementia and these neurodegenerative diseases is different than Alzheimer's, right? And so I think you really need to learn about that and learn how there are more opportunities in some ways to stay connected. The person is still aware of what's going on. They still can engage in a different way than Alzheimer's. So make sure to check your assumptions. So for both of you, how do you find meaning? How do you find meaning in this? What does this mean for you that you're on this, life journey, this journey that includes your illness? Um, how do you, again, find that balance, that gray area of control and acceptance? What can you do? What can you not do? So I'm a big fan of the serenity prayer where you're recognizing what's within your control and what's not, and really focusing your energy on the things that are within your control and trying to accept the things that aren't. Broaden your identity. So that doesn't mean, okay, I'm a person living with HD or Parkinson's or whatever, but it's, okay, who am I now? Who was I when I was 20? Who was I when I was 30? Who am I now? How do I want to spend my time? Manage those mixed emotions. Again, hold on and let go. Lots of both and. Imagine new hopes and dreams. I hear a lot from families about like, okay, well, we're gonna, travel more. We're gonna do something really fun for the grandkids. We're gonna, create we're gonna make over the room and the kids' room in the household, whatever it is, like what is gonna bring meaning to your life? What is gonna bring joy? Um, and it can be simple. One person that I know got a not a subscription, but like one of the movie theaters, you can buy like a pass where you get to go frequently. And so they had this goal of like, I'm going to watch a movie every week, which doesn't sound like a hope and dream, but it was something that brought him great joy. And then taking the time to mind yourself. Again, how do you take care of yourself? How do you take care of yourself in the midst of the usual challenges, the challenges in this time period, and then the challenges that, this illness brings on for you? And I really think it's getting more support. It's really hard to do it alone. Okay. The good enough relationship. So it's none of us are perfect. None of our relationships are perfect. How do you, again, kind of shift your mindset about that? How do you accept it? Accepting that isn't giving up. It's just acknowledging the reality of our humanity. Um, and how do we accept how this is impacting our relationships? What do we still have? What can we do? And when I said, what can we do even if it's not returned? So again, if someone's apathetic, if someone, is changing due to their illness, if the person who's not ill or doesn't have the neurodegenerative disease what can they do intentionally because they're able to, and knowing that it might not be reciprocated? How do you make peace with that? Because in the past, that would have been really weird. That would have been very uncomfortable. So I really encourage you to reflect on that and think about like, okay, here's what we were in the past. Here's who we are now. We often just like, giving gifts can sometimes be more satisfying, more joyful than receiving them. Um, when we're intentional about giving and thinking about how that helps that person, how that helps us, how that helps the relationship, it can pay off in just these small ways. Um, and the good enough relationship does not mean lack of boundaries. So you do not have to sacrifice everything for the relationship or everything to the illness. I, and that's a balance. And sometimes people need to, hear from other people where that balance might be and figure that out. Okay, shifting to the Gottman method. Gottman method is based on research that this couple, Julie and John Gottman, have done for decades and decades. They had a lab. They would observe couples. They would like track their, perspiration and their heart rate when they started to have conflict, and they would watch and they recognized patterns in how people manage conflict and how they created connection when, before the conflict, during and after. So this is for everybody. Um, this I think can be helpful at any time in the relationship, in the course of the disease. If someone is already experiencing a lot of cognitive changes or having behavioral changes, I do think more kind of falls on the partner. So if possible, it'd be great for both of you to do this work. If not, again, it might be that the partner who is more capable at this moment is going to take more of this on. Experiment, give it a try. Let's see. So this says couples require 5 times more positive interaction than negative. So that means that when you have conflict, when there's a slight, when you make a face, and when you are grumpy, then it takes 5 more positive interactions to get back to normal. Normal. Um, when, for example, someone with HD is grumpy, they may not be able to give those 5 positive interactions. So, what does that do for the person who's the partner? How do you remind yourself of that fact that they aren't able to? How so that you're thinking about it, but then also processing the emotions around that. It's gymnastics. It really is. And that doesn't mean that the person living with the disease doesn't always also experience, hey, that was negative. I need positive too. But if the person who's ill can't give it to the well partner, how do you find it for yourself? How do you find that connection with other people? How can you, think about past positive experiences? Again, it's a lot of work, but I think that if you start experimenting with using some of these strategies, your well-being will improve and you can be a little more flexible, be a little more resilient. Um, Again, it's it's not easy, but I think well worth it. Okay, so here again, this is just generally some of their research, not to do with chronic illness. Here are what they call the four horsemen of the apocalypse in relationships and how to stop them. So, as you can imagine, if you're criticizing, verbally attacking the other person, it doesn't go well. So instead of, being like, you're always whatever, rah, 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 using what they call a gentle start up, using I statements. So, hey, I felt really annoyed when you didn't take out the trash. Um, it would be really helpful to me if you would, or if you would let me know, or whatever it is that you need. Contempt is attacking the person with the intent to insult them, you know, and that sometimes happen. People have this negativity. So how do you remind yourself of your partner's, good attributes? How do we, focus on the positive and balance that? Again, you might need 5 times more than the negative. People become defensive instead of taking responsibility. And people engage in stonewalling, so sort of shutting things off to avoid conflict. And they recommend taking a break to soothe yourself. And that's often like, doing something else that's distracting, meditating, going outside, whatever's going to help you feel better, and then coming back to the conversation. Again, this is complex. This is hard for everybody. And depending on where someone is with the illness, this might not be realistic. But can you both consider this, you know, experiment with it, um, and see if it might be of help? Okay, here is their theory on the sound relationship house. So they have this idea. You can't see the other side. The left side, at least I can't see it, it says trust, and then the right side is commitment. So, like, trust and commitment are the two pillars holding up the house. The foundation is building love maps. I don't love that. But basically, it's like know each other, connect with each other, know what someone's into, know what they don't like. You can bring them their favorite dessert. You can, know what their favorite book is. You can play their favorite song. That, foundational interest in one another. And that might change over time what it is you're interested in. And that awareness might change for the person who is ill. They may not be able to remember in the same way. So, how do we navigate that? Sharing fondness and admiration, so affection, turning toward instead of away. So, when you're frustrated, you might take a break, but trying intentionally to reconnect. So they call this bids of affection, bids for connection. So when the person is reaching out, trying to connect, does the other person respond or do they shut it down? So, like, one of their examples is somebody was like, "Oh my gosh, there's a blue jay outside," and trying to talk about the bird. And so does the other person go and look too and go, "Oh my gosh, that's so beautiful, whatever. Oh, that's so cool. Thanks for noticing." Or do they go, "Yep," and go back to whatever they're doing, go back to their phone? So these recognizing bids for emotional connection, whether that's you being intentional about creating them or being intentional about responding to them. And again, in the context of illness, recognizing what's actually possible. And then giving your partner the benefit of the doubt, just starting from the place that you're on the same team. That can be really hard to do when there's a history of conflict. That can be really, really challenging if there's resentment. How do you kind of bring yourself back to that? Again, I think it's something that you can do with help, maybe journal, talk to a friend, talk to a therapist. Um, then managing conflict. So recognizing that conflict is natural and it actually is an opportunity for you to understand each other and, address problems, practice self-soothing. Um, and then making life dreams come true. Create an atmosphere that allows each person to talk about their hopes and dreams. And again, that can be difficult when the story for your life has changed because of a diagnosis. So in that context, now that you're on this other path that is not as cute as the one that you had planned for yourself, what do we hope for now? What do we look for? How do we make the best of this? And really, talking about that and dreaming together. And then creating shared meaning. So thinking about your relationship, understanding each other, that again, the story, the narrative of your relationship. And then those two pillars, trust and commitment. So, I think those can be challenging as things go through. Again, as a relationship changes, I think that the trust and commitment are things that can really matter for both of you, can really allow you to continue to move forward. Okay, so I'm put this here because, again, just a reminder that you're in this relationship because you do love each other. And how do we help you stay connected to that day to day? So, real quick, because this is a little, back in the weeds. When we know that someone is going to develop cognitive changes, you can plan for it. This organization, End of Life Washington, really focuses on helping people plan for end of life and be intentional about it. So they created this dementia directive. So there's advanced directives, medical directives, usually financial directives, where the medical directives are like, here's the person that I want to make my decisions when I can't make my own decisions. I want all the life-saving measures possible, or don't leave me on life support, don't break my ribs with CPR. I do want a feeding tube, I don't. So this is more about planning for dementia. So there's a part of this. This is not the only section, but I wanted to highlight for you that you can go look at this. You can fill it out. It's not legally binding, but it's guidance for your family, for your friends, for your partner. Um, and so it says, continuation of my intimate relationships with my partner or spouse. You can choose all of them, cross out the ones that you don't like. And so it's talking about, your intimate relationship, your sexual relationship. Would you want that to continue even if you're no longer able to verbally consent, or not? And then your preferences. This is one that, depends on your values, depends on how you think of relationships. But, regarding relationships outside of your partnership. So I understand this illness may last a long time and I won't be able to be in the relationship the same way. And that, my partner could engage in another relationship and I'm okay with that, or I want that. Or, my ethics, my values, my religion says we need to stay faithful to each other through the very end. And that's what I want. Um, or I'll let my partner figure it out. Um, Oops, one more. Okay. And then future relationships. Sometimes people move into the nursing home and fall in love with the guy down the hall. And that might be okay for your relationship. That might add something to the quality of life for both people, to allow that to happen. And again, for other people, that would just be horrible and would feel very uncomfortable. So think about that, talk about that. Um, I talked to someone the other day that their ex person that they were still caring for got married to someone else that they met in the nursing home. It happens. So I put this here again, sorry to be so HD focused, but um, there's these HD centers of excellence where there's a multidisciplinary team, interdisciplinary team that focuses on that disease. But really, this is just to say, work with your medical team. They know your illnesses. They have ideas about how to help you. That might be medication, that might be therapies, that might be them just educating you on what might be happening. There's a lot of taboo in our culture to talk about problems, first of all, to talk about, our relationships and what might be happening, about sexuality. These medical professionals are trained, they want to help you. Some of them are going to be better at than others. I think the team here at ECU is super excited about helping you in all these ways. They want to have these conversations. So don't hesitate to, bring it up. I was saying the other day when we spoke, when I was talking to Dr. Bissonnette and Ginger, that I, really care about this. And I find that we're not having these conversations as often as I would like. And I really think it's because our visits are very full. We're focused on, okay, this symptom and that symptom, and what are we going to do? And it can be easy for this to kind of go on the back burner and us never get around to it. So I'm going to again try to be more intentional about presenting it as a topic of discussion. Maybe it matters and people want to talk about it, maybe not. But also, feel free to bring it up. Please, this matters and we want to help quality of life. Um, and again, here are some support groups that you can do. HDSA has some virtual ones through this website called Hey Peers. There are a ton of in-person and virtual groups across the country for Parkinson's, for MSA, for PSP. So reach out to your disease organizations. Get a therapist. Your therapist may not be an expert in your disease, but they are an expert in being a therapist. And their code of ethics says that if they're going to work with you and you have an illness, they need to go do a little Google. They can call us. So they are, super willing to go learn, to learn from their reading, to learn from you and your particular experience of the disease. This website is pretty great because it shows profiles of all the therapists that you can refine the filter, the search for your insurance, their area of expertise. You can click a box for chronic illness. There's not one for these particular diseases, but chronic illness, grief, um, trauma. Sometimes there's trauma involved with, being sick or your experience of the disease. Um, Go get help. This is not full. This is not everybody, but it's a great resource. You can also contact your health insurance company or your, doctor's office. There's also, therapists who specialize in um, sex therapy, sexuality. You could look at that. And again, change is part of life. Relationships change for all of us. Your relationship has already changed. And then now we have this illness as part of it, you know, recognize that, accept, what you can't change, and, focus on the things that you can. Here's my references, and here's my phone number. Okay, there were no questions. I've given no answers. Does anyone want to talk about anything?
Thank you so much. That was great. Feel free to put questions in the chat or raise your hand if you'd rather just speak and we can let you talk.
Or it's like early on a Saturday. This was enough. It was too much,
It was
and
good.
we can let it go.
There's
All
a
right.
hand.
Okay. So you can type it in the Q&A or you can unmute.
Can you hear me?
Yes.
Yes.
Okay, on the end of life form that you said Washington, what is it, Washington put out?
Yes.
Did I misunderstand? Let's see. Yeah, end of life. At one point where you were going through the questions, um, it said if your spouse feels, I don't know what the exact wording was, but if you're acknowledging that your spouse, let's see. Mm-mm-mm. I think it's up another one.
Okay.
Um,
There's three.
oh yeah,
So there's
that
another one.
you understand that last screen right there.
Yes.
Oh, up one.
Oh, number two. Okay.
Okay, right there. Um, okay, where it says that they will no longer recognize to function emotionally or sexually and could be involved in other relationships. So, what are you giving your partner consent?
You're giving your partner consent.
Is that what it's saying?
Yeah, I think it is. And again, this is just an example. I mean, you can make it your own. You could type up your own. I think it's important just to have the conversation. So it doesn't
Mm-hmm.
have to be this specific wording, but I think the idea is that for some people, they want to encourage their partner to engage in
Move
other
on.
relationships even when
Yeah.
they're still alive. And again, I mean, it's very personal. It really varies. Um,
Hmm.
but I have heard people say this. I've seen people do this and make a choice. And, the person who's not living with the disease start another relationship while they're still caregiving. Um,
Right. No, I think it's very important to have one of these forms.
I do too. And I think, the important thing to consider with this and really any advanced care planning is that it can change. I mean, you can fill this out, you can have this conversation, and if it's different later, you can do it again and change it.
Right.
But if anything, it just allows you to discuss the things that we tend not to discuss and really, hear from one another what you would want.
Right. Thank you.
Yeah, thank you.
There was another hand earlier. Did someone else have a question?
So the person earlier was asking to see the references. So I'll go back to that, but I see another question. Um, how can a great respite care place be found that can care for your loved one's complex needs, especially if the caregiver must be away because of other obligations, family obligations, employment? Um, it is difficult to find a great facility. None of them are perfect. I think it's important to go into it knowing that and that we're just looking for, you know, the best possible. I don't know, my literary brain is going to Candide, the best of all possible possibilities, but that's just it's a little unrealistic to think it's going to be perfect. Um, I think working with your healthcare team is a great start. Sometimes there are organizations in the community that can help you. So, for example, HDSA has social workers across the country. The Alzheimer's Association is available to everybody that has a diagnosis that can create cognitive changes, not just Alzheimer's, but also Parkinson's dementia, HD. So they have folks that do care planning and can help you evaluate places. Um, you can go to, it's a little confusing, hear me out. You can go to the Medicare website. That does not mean that Medicare will pay for this care, but Medicare evaluates facilities. Sometimes your state will have, reports on safety. So Medicare, if you Google Medicare Care Compare, it has their data on the performance of different facilities, including hospice agencies and home health care agencies and nursing homes. And so you can see, like, did the smoke detector work? Did they have the right staffing? All that kind of stuff. I've also heard people like look at Google reviews. Um, but I think, going and visiting um, can give you a good sense. There's some, questions to ask yourself available online. If you just Google, like, how do I pick long-term care? There's questions. I have some available if you want to reach out to me. Um, it's not easy. It's very emotional typically for everybody, but I think it's important to recognize and to acknowledge that this is outside of our control. The disease often makes it so that it's not possible for people to stay at home. And that's not a failing of anyone. It's really that the disease is hard. So it's important to have those conversations and get a social worker involved to help you navigate that. Um, but yeah, I hope that helped.
Yeah, I was going to reiterate that at VCU, we do have social workers both in our clinics, but also broadly, who have been compiling lists of places where some of our patients have been, so that we know they've had some experience with certain diseases. So definitely reach out to us and ask. Respite is interesting because not everyone does the short-term respite, but I've
Mhm.
definitely had families where if you can get into a place for respite, sometimes that actually becomes a nice opportunity down the road if long-term care is needed because you know that your loved one is cared for there because you've had that experience and you also know that they're comfortable. So I've seen patients actually transition into being residents at places where they did some respite because they enjoyed the people who were there. Yeah, great question. The start for social work with us, I would say, is to um, sorry, I got distracted by the second question. Um, Either send a my chart message to or call our main number, and I always forget it off the top of my head, to whoever your provider is, and they can set you up with a social worker, and then the social worker can reach out. Right now, we're working with a social worker, Latoya Rivers, and she's been very responsive and is looking to help people. So either again through your my chart or the main neurology number, saying that you want to be connected with a social worker in the movement disorder center, and we can get you all sorted out. Thanks, Joseph. Was there a question in there? Ah, good question. I'm gonna let Amber cover that one.
Yeah, that's a great question. Okay, so Joseph's question was, can physical therapy help with that? I'm not sure what that is, but yes, I think generally physical therapy can help.
I think it's we love to kiss, and I can't do that very well.
Oh, I see. I see. Yeah, that's tricky. Well, my technical answer would be fine motor skills or occupational therapy, not physical therapy, right? So like your face. I don't know if occupational therapy can help with kissing. So, um, the dystonia. So I wonder, he mentioned dystonia. So I wonder if treating the specific symptom could be helpful.
Yeah, and it's possible that you've already tried medications, but there are some medications specifically to target dystonia. There's also, okay. There's also Botox, which I know, we're working on. But I would say, yeah, occupational therapy may be a really nice route to work on this and have like a joint session with you and your partner, where they can actually help with techniques or positioning or things like that. I'm going to make myself a note to reach out to our occupational therapist and see what her ideas are.
I
Thank
think an occupational therapist would be super excited to work on this because they're
you.
really focused on quality of life. They're really focused on practical things, and they may have already taken this on with someone, and I think it'd be very fun.
Yeah, I would
How
say,
about that must be very frustrating.
let me know, send me a message in a week. I wrote down that I'm going to try to talk to Molly this week when I see her, but yeah, let's work on this. It's a great idea. These are great questions. Thank you all for engaging. Any last ones? Oh, before I give a plug for our next session.
Thank you all for your time. Thank you for having me. I hope
Thank
this was
you
helpful.
for joining us, and thank you for getting up so early. We greatly appreciate it. Francie, I wish I could thumbs up that for you. That's great. Uh, Our next session, for those of you who are interested, is actually going to be on estate planning 101, and it's going to be by Carolyn White, who is a local estate lawyer here, and that's going to be on March 21st, again starting 9:30, and it's a Saturday, 9:30 to 11, Saturday morning, and then May 16th will be our spring session, which will be a research update on Huntington's disease by Dr. Alex Dalrymple, who's from the UVA HDSA Center of Excellence. So please join us for those. Thank you all again for logging on. Thank you, Amber. This was really
Thank you.
wonderful. Um, and we, would love to continue talking about this. So we'll
Yeah,
keep in touch.
sounds great. You'll have a great Saturday. Thanks for your
Thank
time.
you. You too.
Thank you. Bye bye.
Bye.